This is the case study presentation for Nursing 667. The selected patient is a 20-year-old white female who has some college. She's 5'4", she weighs 150 pounds. Her BMI is 25.74 with a BSA of 1.75. When she initially presented to the psychiatric facility, she stated, "I'm seeking treatment to better my mental health. I was referred by my doctor. I feel sad and anxious and want to be better." This patient has a history of mood and anxiety issues, which began after an episode of sexual abuse by an extended family member at age 9. She had brief therapy for a time, but her anxiety and depression worsened over the years. Currently, she continues to feel depressed and her anxiety is worsening. She is also now exhibiting symptoms of OCD with counting behaviors. The patient says her father once was diagnosed with OCD. The patient currently does not have a designation of OCD. The patient's past psychiatric history. Her symptoms began at age 9. The initial causative effect was sexual abuse by a family member. The age at which her first contact with psychiatric services is right now. She has 0 lifetime suicide attempts, although she has been hospitalized in a psychiatry unit by Baker Act once. Her father is the only one in her family who has a psychiatric history. He has a diagnosis of anxiety, depression, and bipolar. The patient is currently single, identifies as bisexual. She graduated from high school, but declares that she has history of ADHD. Her grades covered the span between A's and F's. The patient claims to be spiritual but does not attend an organized religion. She denies any possessions of firearms. She's employed by a car dealership in Brandon. She currently lives with her girlfriend. Previously, she had just moved out of her family home where she lived with her brothers and sisters. The patient does not currently abuse any illegal substances. She does, however, use caffeine. She uses 1 drink a day. The patient currently suffers from headaches frequently and has premenstrual syndrome. For her mental status exam, her general appearance, she was neatly dressed without notable distractions. Her hygiene was good, her clothes were normal, her hair normal, eyes normal, and body normal. Her attitude and behavior is concerned. Her mood is depressed and anxious. Affect is concerned. The patient denies suicide ideation. She denies homicidal ideation. She denies hallucinations, visual or auditory. She denies having any delusions or ideas of reference. The patient's thought process was linear, logical, and goal-directed. Her sensorium was clear. Her executive functioning was slightly impaired, and her abstract thinking was suboptimal. The patient is in some denial, and her judgment is intact. She appears reliable, and there were no gross deficits observed of her cognition. The patient's DSM-5 diagnosis was chronic post-traumatic stress disorder. The NANDA diagnosis is risk for violence directed towards self or others, related to intrusive memory, rage reactions. She has ineffective coping related to stress as evidenced by disinterest in present and distant team from support. Her second diagnosis is moderate recurrent major depression with a NANDA diagnosis of ineffectual individual coping related to situational crisis as evidenced by verbalization of inability to cope reported life stress, and alteration in social participation. Her final diagnosis is generalized anxiety disorder. The NANDA diagnosis is anxiety related to actual perceived threat to health as evidenced by increased tension. This 20-year-old works as a receptionist at a car dealership. She had her first encounter with depression after being sexually abused between the ages of 9 and 10. The perpetrator was an extended member of the family. After the incident, she had a brief series of therapy, but her anxiety depression worsened over the years. She currently continues to feel depressed with anxiety. The patient engages in risky sexual behavior. She describes a recent encounter with a coworker where they went out one night after work and ended up having unprotected sex. The next day, the coworker cut off all communication with her, despite the fact that they work in the same building. The patient finds herself trapped in her current relationship with her same-sex partner. She says she feels controlled and mentally manipulated by her. The patient broke up with her partner for a few months, although they still share the same dwelling. This adds to the sadness and depression. The patient currently sleeps on the couch. Her ex desires to have a relationship with her again, but the patient feels manipulated and that this is just a controlling tactic. She says that when they are together as a couple, they only engage in sexual activity once a month. She feels like it's all her fault and that she's undesired. She also feels like she denies her this just to keep her controlled. The patient believes that her partner does not want her. She also feels like even though they're not together, her partner does not want her seeing anyone else. She feels that's the reason the partner stresses that they want to get back together. The patient is generally not happy, and her partner makes it seem like she is the one who causes all the problems in the relationship. The patient says she's always trying to live up to her partner's expectations, and she's always trying to fix everything that's broken. She feels unsupported during her emotional turmoil. When her sadness overwhelms her, her partner will disengage and leave her. She said she can't deal with the patient when she's like that. Her partner doesn't want to be around her, and her partner tells her that she will never be happy with her unless she gets fixed. The pathogenic factors to this patient's mental health. She's a sensitive person who felt unable to confide in both her mother or father due to her sexual abuse, which led to her depression. Her feelings were depressed, repressed, and internalized, and she developed a false, compliant self. Her main defense mechanisms are repression and passivity. The patient has poor self-image. This contributes to her depression. She is not assertive with her interactions with her partner or others. She fears rejection, which further leads to interpersonal problems. This causes her to withdraw from developing friendships. The patient is treated with hydroxyzine. Hydroxyzine is an anxiolytic antihistamine. It is commonly prescribed for anxiety and tension associated with psychoneurosis. It is also prescribed for short-term symptoms of anxiety. The goal of treatment is the remission of symptoms. It is often used for chronic anxiety disorders. This treatment can eliminate or reduce symptoms, but it is not a cure. It is often used as an augmentation for SSRIs and SNRIs. The patient is also taken Zoloft. Zoloft is an SSRI, a selective serotonin reuptake inhibitor. It is an antidepressant. It's used for major depressive disorder, premenstrual dysphoric disorder, panic disorder, social anxiety disorder, obsessive compulsive disorder, and generalized anxiety disorder. This drug works by boosting neurotransmitter serotonin. It blocks the reuptake pump. It can also block dopamine reuptake. The following labs were ordered for the patient: vitamin B12 and folate, iron, TIBC and ferritin panel, and a respiratory allergy panel for Region 4. Some of the evidence-based non-pharmacologic interventions were psychotherapeutic interventions. The education was provided on the impact of trauma on the brain. We discussed the concept of alarm system being turned on for constant false alarms and therapy types to reduce all impact and improve long-term function improvements. We also discussed the severity of symptoms. We employed active listening while the client described frequency, intensity, duration, and history of her symptoms. The assessment of her symptoms indicates that these symptoms are moderate and occasionally interfere with her daily function. We assessed her level of insight. Toward the presenting problems was assessed. The client was noted to demonstrate good insight into the problematic nature of the behavior and symptoms. She was also noted to agree with others' concerns and is motivated to work on the change. We monitor her compliance with her prescriptions for psychotropic medications. The client reported that her medications have been beneficial to her in reducing her experience of the target symptoms, which formulated the basis for the treatment adherence. The client was assisted in recognizing her emotional responses as involving different components that go through predictable phases. We did this through motivational interview techniques to help her clarify her stage of motivation to change. We also assisted in identifying her dissatisfaction with the status quo and the benefits of making changes. She was assisted in identifying her level of optimism for making those changes. For her anxiety reduction techniques, she was taught how to recognize, stop, and postpone worry until they agreed upon worry time. Skills were taught to her, including thought stopping, relaxation, and redirection of attention. The client's fears were analyzed by examining the probability of her negative expectation becoming a reality, the consequences of that expectation if it occurred, her ability to control the outcome, the worst possible result if the expectation occurred, and her ability to cope if the expectation occurred. We looked at her identified distorted thoughts. We assisted in identifying her schemas and related automatic thoughts that mediate anxiety responses. She was assisted in replacing distorted messages with positive, realistic cognitions. She was also taught sleep hygiene. We reviewed practices, reviewed for success, and provided corrective feedback toward improvement. Regarding PTSD, she was given an opportunity to share what she recalls about the traumatic event. We then assisted in identifying the connection between thoughts, feelings, and emotions that are associated with trauma. We educated the patient to take medications as directed and to not miss any doses. We educated her to make sure that she keeps her counseling sessions and follow-up appointments. She was instructed to recognize and accept her anxiety. Therefore, she can tell herself not all things are an emergency. She is allowed to feel uncomfortable, but she's still not in danger. And finally, she can keep going even if she feels anxious. She was instructed to treat her body well and that she should engage in exercise and/or massages. She should get plenty of rest, and she was recommended to avoid alcohol, nicotine, caffeine, and especially illegal drugs, as these increase anxiety levels and can cause her to lose restorative sleep. She was instructed on how to do relaxation techniques. The patient was referred to psychotherapy to work on ways to improve communication skills, to be able to learn to request needs within love languages, as they are not hard principles to be demanded or guaranteed, but rather a guide for identification and expression to build upon within attachment. She is also being sent to therapy to review and manage anxiety skills. This concludes the presentation. Here are the references. Thank you.